Welcome to the Deep Dive Ortho. We're here to really unpack those complex orthopedic challenges, giving you the insights that will actually make a difference in practice. Today, we're honing in on olecranon stress fractures, specifically looking at throwing athletes. Now, this is an injury that, historically perhaps wasn't seen quite so often, but it seems to be cropping up more and more. And it presents some, let's say, unique diagnostic and management puzzles, particularly when you're aiming to get athletes back to peak performance. I'm really pleased we have Professor Mo Imam joining us today, a real expert in this area, to guide us through it all.
Thank you. It's great to be here. Yes, understanding this injury is, I think, increasingly vital, and not just for specialists managing elite athletes, actually. It's relevant for anyone seeing patients involved in repetitive overhead activities. It's definitely a condition where shall we say, practical, evidence-based approach really impacts the outcome.
Absolutely. So before we dive into the mechanics of how these happen, and maybe just set the scene for us, what exactly is an olecranon stress fracture? What are we talking about fundamentally?
Okay. Well, fundamentally, it's an elbow injury that results from repetitive loading. Simple as that, really. Now, while we associate it most strongly with throwing athletes, baseball players, cricketers, we do also see it in gymnasts, weightlifters, even tower diving swimmers, javelin throwers, anywhere with that repetitive overhead action.
Right.
Anatomically, in younger athletes, it often involves the growth plate, the epiphyseal plate. The fracture lines themselves can be transverse or oblique. And, from an epidemiological view, upper limb stress fractures are generally becoming more common.
Mm-hmm.
The olecranon itself is actually the fourth most common site for any stress fracture, about 8.7% in one analysis. But get this, for baseball players, it's far and away the most common site. Makes up something like 58% of their stress fractures in one review.
Wow, 58%. That's huge. That really highlights it's not just a random injury, is it? It's a distinct pattern in certain groups. Which brings us straight to the why. What's going on biomechanically? What leads to these fractures? Is it one thing or sort of a combination?
That's a key question. It gets right to the pathophysiology. The core problem is repetitive microdamage happening faster than the bone can repair itself. It just can't keep up with the remodeling demands.
Okay.
In throwers, we generally talk about three main mechanisms, often acting together. First, there's olecranon posteromedial impingement. Essentially, the tip of the olecranon repeatedly banging to the back of the humerus, into the fossa, during that extreme throwing motion.
That forceful end range extension.
Exactly. Then second, you have triceps traction force, that powerful pull from the triceps muscle, especially during the acceleration phase of the throw. Or, in weightlifters or gymnasts, it might be more of an impaction force from that triceps pull combined with overextending the elbow.
Right.
And third, the classic culprit, valgus extension overload, often called pitcher's elbow. This involves that repetitive sideways stress, the valgus stress, combined with impact and shearing forces right along the posteromedial olecranon.
So it's a combination of stresses really hammering that one area.
Precisely. And it's important to see these not just as separate things, but as a kind of spectrum of progressive damage that eventually results in the fracture. And another really interesting point, well, clinically very relevant, is how often these occur alongside other injuries, especially in throwers,
Yes.
such as, most notably, ulnar collateral ligament UCL tears. Some studies show this happens in 71% up to 95% of baseball players with olecranon stress fractures.
70 to 95%. That's incredibly high.
It is. And we also see medial epicondyle avulsion fractures sometimes. The crucial thing about that UCL insufficiency isn't just the instability. It actually changes where the peak load occurs on the olecranon. It shifts the stress point, which accelerates fatigue, even if the throwing mechanics look okay superficially.
Ah, I see. So the ligament damage alters the joint's mechanics under load.
Exactly. And all this highlights how the specific sport, the athlete's age, their skeletal maturity, particularly whether that growth plate is closed, all influence the injury pattern and how severe it is.
That link between UCL integrity and load shift is a really important clinical pearl.
Okay, so knowing all these complex mechanisms, how does this actually present? What should we be looking for in the clinic? What are the telltale signs?
Clinically, the typical story is pain, usually quite localized to the posteromedial aspect of the olecranon in their throwing arm. The key feature is that it gets better with rest and much worse with throwing. Often starts as a dull ache, maybe progresses to quite sharp pain.
Okay.
On examination, you might find a bit of mild swelling, some localized tenderness right over the bone. Interestingly, they often have full elbow range of motion, which can sometimes be misleading.
Right, so don't rule it out just because the movement seems okay.
Exactly. But doing a valgus instability stress test is vital. That can flight up that associated UCL injury we discussed. And occasionally some reports mention pain with resisted supination, though that's less common.
And differential diagnoses, what else could it be? Good point. You definitely need to consider triceps tendinitis, osteochondritis dissecans of the capitellum, maybe a chondral injury, and general post-remedial elbow impingement. All can cause pain back there.
Okay. So, given that it can be subtle sometimes, especially early on, what's your approach to imaging? What really nails the diagnosis and helps differentiate?
Well, first step is always plain radiographs. Standard AP, lateral, and oblique views. You might consider stress views or comparing to the other elbow sometimes. Findings could be subtle, maybe physical widening in a younger athlete, delayed fusion, perhaps some fragmentation. Or if there's a UCL injury, you might see the medial joint space widen slightly.
But they can be normal initially.
Absolutely. And that's a crucial point. A distinct fracture line might not be visible at all, especially early on. There was a well-documented case of a 17-year-old pitcher where the X-rays were initially clear.
Right. So if you suspect it, but the X-ray is negative.
Then you move on. CT is very good for actually seeing the bone detail, the fracture line itself. Best seen on the lateral views, usually starting at the joint surface and running backwards and upwards.
Okay.
But for the definitive diagnosis, and especially if you suspect a UCL tear, MRI is really invaluable.
Mm-hmm.
Coronal T2 fat-saturated sequences are key. They can show things like bone marrow edema, that stress reaction even before a fracture line is visible anywhere else, or they might show the T sign, indicating a UCL tear. That's why early MRI is so important. It detects the stress injury much earlier.
That early detection is crucial for management, isn't it?
It is. And talking about patterns, classification systems can be quite helpful here. There's one by Furushima and colleagues, which is quite neat. It divides them into 5 types: physeal, classic, transitional, sclerotic, and distal, based on where the fracture starts, its direction, and importantly, the average age they tend to occur.
Oh, interesting. So age-related patterns.
Yeah. Yes. For instance, the physeal type is typically around 14 years old, while the classic type averages about 18 or 19. It really highlights how skeletal maturity influences the fracture type, which can guide how we think about managing it.
That's a useful framework. So once you have that confirmed diagnosis, what are the main treatment routes, non-operative versus operative?
Exactly. So non-operative is generally the first approach, particularly for those early stress reactions without a clear fracture line. This means primarily rest. Strict rest, usually 4 to 6 weeks initially, often meaning complete time out from their sport for up to 3 months.
3 months is a long time for an athlete.
It is, but it's often necessary. We combine that with pain control NSAIDs, typically, and sometimes brief splinting or maybe a hinged elbow brace for protection. Then careful rehab begins. Progressive range of motion, but crucially, avoiding any valgus loading, so no throwing. We might consider things like electrical bone stimulation or checking vitamin D and calcium levels just to optimize healing conditions.
Right.
A gradual return to throwing program usually starts around 2 to 3 months, assuming they're pain-free.
And the outcomes for non-op?
Generally very good. Symptom resolution happens in nearly all patients treated this way, taking around 20 weeks on average. Radiographic union, seeing the bone fully healed on X-ray, can take longer, maybe closer to 30 weeks. But the return to sport rate is high, most getting back to their previous level.
And the big advantage is avoiding surgery.
Precisely. Avoiding those potential surgical risks. However, operative treatment definitely has its place.
What are the main triggers for considering surgery?
Indications would be things like delayed union, the fracture just isn't healing, or a true fracture with displacement. Also, what we call an apophyseal non-union, or simply failure of that non-operative approach. So, persistent pain, ongoing non-union, or if the fracture displaces despite rest. Actually, one systematic review found over a third of patients needing surgery had tried and failed non-op treatment first.
So it's not uncommon for non-op to fail then.
It seems a significant minority do end up needing surgery.
And the surgical techniques, what's typically done?
Most commonly, it's open reduction and internal fixation, ORF, usually using cannulated screws that accounts for about 77–78% in one review. Other options include tension band wiring with K-wires, sometimes bone grafting if there's a non-union, drilling the fracture site, or occasionally excising the very tip of the olecranon if it's problematic. Looking at the data, a majority of these elbow stress fractures, maybe around 77% in that review, did end up being treated operatively.
And outcomes after surgery?
Again, generally very good symptom resolution, 97.5% in operative patients, often a bit quicker than non-op, maybe around 16 weeks on average. Radiographic union also tends to be faster, perhaps 14 weeks or so.
And return to sport?
Also very high for both groups overall, about 96% return to their pre-injury level, or even higher in that systematic review. But, and this is important for counseling patients, the average time to return to sport was actually longer for the surgically treated group, around 26 weeks compared to 16 weeks for non-op.
Longer after surgery? That seems counterintuitive.
It does, doesn't it? Though we have to be cautious, as the reporting for the non-op return to sport times was a bit limited in that review, so the comparison might be skewed. But it's something to bear in mind.
Definitely. Important for managing expectations. That naturally leads to thinking about downsides. What are the potential complications, particularly with surgery?
Yes, that's a really crucial consideration. The complication rate isn't insignificant, reported around 17.3%, and importantly, these were all following surgical intervention.
Okay, 17%. What sort of issues?
The most common one by far is needing the hardware removed later on.
Yeah.
That happened in about 15% of cases, usually due to painful irritation from the screws or wires, or sometimes infection. Infections, when they occur, need proper management, washout, debridement, antibiotics, and then taking the metalwork out later. Other less common things include ulnar nerve impingement, which usually sorts itself out with a surgical release. And unfortunately, persistent elbow pain can be an issue. One patient in that series couldn't get back to sport because of it. And finally, revision surgery was needed in nearly 6% of patients.
Why would they need revising?
Usually due to fracture displacement, which, as you can imagine, often ties back to noncompliance during rehab, perhaps returning to activity too soon. Or sometimes for fracture, even up to a year later. This might suggest maybe the initial union wasn't quite as solid as thought, or it could be a recurrence from overuse again.
So patient compliance is paramount.
Absolutely critical. Thorough education and sticking rigidly to the rehab plan are key to avoiding some of these post-op problems.
That detailed look at treatments and complications is so useful. So, Professor, as we bring this together, what are the absolute key takeaways for colleagues managing these injuries? What should they really keep front of mind?
Okay, key points. First, have a high index of suspicion, especially in those high-volume throwing or overhead athletes coming in with posterior elbow pain. Don't dismiss it easily. Second, think about using MRI early. Even if x-rays look normal, MRI can pick up that bone stress reaction, that edema, much sooner, allowing earlier, potentially less invasive management.
Get ahead of it.
Precisely. Third, always consider the sport and the athlete's age. They really do influence the injury type and severity. And linked to that, for younger athletes, keep an eye on pitch counts, throwing mechanics. Prevention through managing load is vital.
Crucial point.
And finally, remember that while both non-op and op treatment generally lead to high return to sport rates, non-op usually takes longer to heal fully but avoids surgical risks. But also keep in mind that a fair chunk of those initially treated non-operatively might still end up needing surgery, so monitor them closely.
Professor Mo Imam, that was a truly fantastic deep dive into olecranon stress fractures. It really highlights that complex interplay between biomechanics, patient factors, and achieving good outcomes.
Indeed. It's definitely an area where understanding those nuances guides successful management. I hope this discussion has been helpful.
For you, our valued listener, we really hope this conversation has given you some clear, practical knowledge for your own practice. If you found this deep dive valuable, please do take a second to rate and share the Deep Dive Ortho. It really does help us reach more colleagues like you. And maybe just a final thought to leave you with. How can we use this deeper understanding of specific biomechanical stresses in high-performance activities to develop more personalized, maybe even proactive, injury prevention strategies, rather than just reacting once the injury occurs? Join us next time for another Deep Dive.